And thanks for having me here. It's a huge honor to be here, especially because the Niagara Conference was moved to Miami. It's much nicer to be here now than before. And thank you all for coming, and thanks for allowing me to spend some time here with you today. I want to do my best to keep us on pace for lunch. I know that I'm the only thing standing between you and turkey sandwiches and other things, so I'll move through this as quickly as I can. Is it possible to see the slides over here? No. Did they not show up there? No? Okay. So I want to talk about suicide today, and I'll be talking about trying to improve our ability to understand, predict, and prevent suicidal behavior. What I'm not going to do is talk about, I know I saw a lot of hands for, a lot of you are clinicians. I'll ask you one more time. How many of you see suicidal patients? Kids, adolescents, adults who have thoughts of suicide? Okay, virtually everyone. So I will be talking about suicide and suicidal thoughts. What I won't be doing is talking about sort of advice, suggestions, guidelines for doing clinical assessment and intervention with people at risk for suicidal behavior. Dr. Jeremy Pettit is going to be covering that Friday afternoon in a workshop that if you're interested, I would definitely encourage you to attend. What I want to do instead is talk about, as we've heard in other areas, bipolar disorder, talk about what we don't know, where the gaps are, and how we might try and bridge those gaps. And in particular, I want to talk about using recent advances in technology to try and do that. So I say no disclosure. I've written some textbooks and have grants and that kind of thing, but nothing that I'm going to present is at all related to me financially, so I have no potential biases here. To be very basic, suicide is a very complicated problem, a very complex problem. It's one that we've known about since the beginning of recorded history. For thousands of years, it was in the domain of philosophical inquiry. So if we wanted to understand suicide, philosophers wrote about suicide, and virtually every major philosopher over the years has written about the idea of should we live, should we die, to be or not to be. We have lots of eloquent prose as a result, but not much better understanding of why people try and kill themselves. And this remains one of the leading causes of death. Suicide is the 10th leading cause of all death in the US, 3rd leading cause of death among adolescents and young adults, 2nd leading cause of death among college students. And unlike other causes of death, it hasn't changed much over time. So if you look at rates of cancer deaths or pneumonia deaths or accident deaths over the past 100 years, they've all dropped pretty dramatically. The suicide rate now is virtually identical to what it was 100 years ago, which is astonishing. So we've made some progress, and I'm not going to tell you too much about that progress. We know now what the rates of suicidal thoughts are. About 15% of adults and adolescents say that they've seriously considered killing themselves at some point. About 5% make a suicide attempt at some point in their life. We've learned about a number of different risk factors for these things. We have had some treatment successes, but I would argue that progress has been slow, and I would say fairly stagnant. And I would encourage you to not take my word for it. As W. Edwards Deming has said, in God we trust, all others must bring data. And so I brought data. So Dr. Youngster mentioned meta-analyses earlier. One of our recent postdocs, who is a UNC graduate student, Joe Franklin, and crew in our lab did this enormous meta-analysis where Joe and friends poured through thousands and thousands of studies. You've heard about the sort of method of meta-analyses, looking at what do we know about risk factors for suicidal thoughts, attempts, and death. Over the past 50 years, looking at every study that's been done, trying to predict these outcomes, what have we learned? And one thing that we looked at is, have we gotten better? If we look at the past in 10-year increments, have our odds ratios increased? Has the predictive power of our risk factors increased over time? What we want to see is we're getting better and better at identifying big risk factors for suicide. And I'll show you data for suicide attempts and suicide deaths. So is this line going up? No. It looks like it's slightly going down or about flat. Over the past 50 years, we haven't gotten any better in our ability to predict suicide attempts or suicide death. Why is that? It's because we've been, as researchers, looking at the same risk factors over and over and over again. If we tag what risk factors we've looked at over the past 50 years, for every decade, we looked at the same 5. We look at sociodemographic factors, your age, sex, ethnicity. We look at DSM disorders, internalizing disorders, externalizing disorders. We look at prior history of self-injurious thoughts and behaviors, and we look at negative life events. All of these things predict suicidal behavior. We knew this in 1965. We knew this in 2015. We've proven it. We've shown it over and over and over again. And in fact, 75 to 80% of all the analyses that suicide researchers have done have focused on these 5 factors. So these we've got, but we haven't improved our ability to predict. And so that's not surprising. If we're looking at the same predictors and using the same methods, self-report, interviews done at one point in time to try and predict into the future, it's not surprising that we haven't made many big advances. So we're left with these enormous gaps in our ability to understand and predict and prevent suicidal behavior. How can we bridge these gaps? What can we do differently? What I'm going to argue is we would benefit from really incorporating new technologies to help us bridge these gaps. Might we be successful doing this? I think it's absolutely the case that we will. If we look at virtually all other areas of our lives, we've had huge advances using technology. I'll pick just a random few. If you want to solve a complex mathematical problem, not so long ago, when I was in kindergarten, our cutting-edge technology looked like this, right? But this is called an abacus, for those who haven't seen it. Thank you. Some of you have seen this before. This is how we did math not so long ago. And now if we want to solve complex mathematical problems, we have tools that look like this. So with technology, we've had huge advances. Not so long ago, if I wanted to travel to come to a conference like this, my lab members and I used technology that looked like this. We hiked through the prairies. Now, many of us came in technology that looks like this. Past couple of decades, we completely changed the way that we move about the world and transport goods and so on, using advances in technology. To get into the health sciences, not so long ago, if you had a severe medical condition, you lost a limb, the cutting-edge intervention looked like this, not so long ago. Now we have robotic arms controlled by the human brain. Fascinating. In just the past few years, we've made these quantum leaps. What about in psychology? What about in understanding suicide and predicting it and preventing it? 100 years ago, our cutting-edge technology looked like this, and now it looks like this, right? We're essentially doing the same thing we've been doing with some caveat. I mean, obviously we have advances in evidence-based assessment and treatment, and we've had some big advances. I'm not saying we haven't, and this is the best we have because this is where we are. But the argument is now is the time to try and better understand this really complex, complicated problem and make similar advances using advances in technology. And this is not an easy task, right? This is, although it's a leading cause of death, it's a low base rate behavior. People don't like to talk about it. We don't know when it's going to happen in time and place. It's hard to get interventions out to people when they're not telling us that they're at risk. There's lots and lots of challenges. What I want to talk about is how we can try and address some of those challenges. So what might this look like? I'm going to talk about, there's lots of gaps in our understanding. Because lunch is in a half hour, I'm only going to talk about 3. And I'll pick 3 that I think we've got possibility for traction on. One is we need better methods for combining information about known risk factors. We do this in other areas. If you think about weather prediction, that's just one example. You all have probably an app on your phone, a weather.com app or Dark Sky or some app that uses many different variables, combines them to predict the chance of different kinds of weather events in time and place. When is it going to rain? Almost to the minute. When is it going to rain? Where? And so on. And it does it we can do this for rare events as well, tornadoes, hurricanes, and so on. So in many areas, we've used advances in statistics to combine information from many variables to improve our ability to predict. We haven't done this in suicide prediction, but people are starting to. We need better ways of objectively measuring suicide risk. This is true if you go to a doctor's office. We do a lot of work in emergency departments, and it's really striking. Someone comes in we work in an emergency department where there's a medical side and a psychiatric side sort of adjacent. Someone comes in and they'll have medical tests done, they'll have x-rays, they'll have blood draws, and they come to the psychiatric side and we have questions for them. It's the state of the art, it's what we have right now, but the contrast is really stark. We have now in psychological science objective tests that are being developed that can help us better detect and predict suicidal thoughts and behaviors, but we're not yet at the point of using them, and I want to talk a little bit about some recent advances in this area. And finally, I want to talk about getting data on imminent risk. How do we know, and this is the thing I would assume many of you, as a clinician myself, this is what I'm most interested in. Not can we predict this behavior 5 years from now, but is my patient going to try and kill themselves today or tomorrow or the next day? We don't have any data on that. We have it in other areas. Think about online consumer behavior. I'm sure you've all had this experience. I've got 3 kids. My 10-year-old plays soccer. He's growing, his feet are growing quickly. So I was in my kitchen looking on Amazon for soccer cleats. I didn't buy anything. I stopped, I went upstairs to my home office, and I went on Google looking for something else, and there's ads popping up on the side for soccer cleats and soccer balls and soccer goals. And there are technologies, there are algorithms running on your devices at all times trying to predict what you're going to do and then intervene with you in time, in place, in real time to try and sell you things. Can't we use the same approaches to try and understand who's at risk for different kinds of psychopathology, for different kinds of concerning behavior like suicide? And people are starting to do this, and I'll talk a little bit about this. So a lot of this is going to be not what can you do tomorrow to help improve your clinical practice. Again, I encourage you to see Dr. Pettit's go to his workshop on Friday. This is going to be what do we think is coming down the road to help for students who are here, what you might start thinking about in terms of your work, and for clinicians and others, what might you start looking into and incorporating. So we can think of these as gaps, but also opportunities for making advances. So I'll spend just a few minutes talking about each of these, and I don't know if it depends on how quickly I speak, whether we have any time for questions, but I'll be here, and if you want to talk about these things later on, definitely let me know. And this is going to be recorded. This is being recorded, so if you want to watch this online and slow down the tape to like 60% or so, it'll probably be all intelligible. So we need methods of combining risk factor data. We've identified risk factors, so it's not that suicide researchers have been doing nothing. We've been doing a lot in terms of trying to identify what puts a person at increased risk of suicide ideation, thoughts, attempts, or death. So for instance, this is from Joe Franklin's meta-analysis. We see dozens of risk factors have been identified. These are different risk factor categories, and on the vertical axis here is how much of an increase do you have in risk of suicide death given the presence of that risk factor. If you can't read it, the first bar is for treatment history. Having been in treatment triples your odds of dying by suicide, not because our treatments are killing people, but because people at risk are getting themselves into treatment. Every other risk factor we examine, DSM disorders, negative life events, and so on, have odds ratios of about 1 to 1.5, which means at best, with an odds ratio of 1.5, you've got a 50% increase in your odds of suicide given the presence of that outcome. Sounds like a lot, but if your chances of dying by suicide in a given year are 0.00001, and being depressed increases your odds to 0.000015, it's an increase, but it's a pretty small increase. And so virtually every study that we've done over the past 50 years has looked at one risk factor at a time. What we haven't done is combine risk factors, which is what we need to do to predict this complex outcome that's not caused by any one factor. No one factor does it. It's got to be a combination of different factors. How can we do that? We're asking clinicians to do that when we don't know how to do that ourselves as researchers. With computers, we can't do this. How is the human mind going to measure and weight and combine all of these different variables? Well, what if we start using the same methods that are used to predict whether something coming into your email is spam, or based on what movies you've watched, what other movies you like on Netflix, and so there's lots of different ways that we can look at variables and combine them to predict some outcome. And I'll give a few examples of that. And what research is starting to do is using machine learning or statistical learning approaches to look at samples of data, large samples of data, learn what are the things that predict suicide, and then apply them to new cases. And so as one example, Ron Kessler and colleagues at Harvard Medical School got a really large sample of data on Army soldiers. The suicide rate among Army soldiers has been increasing dramatically over the past decade. And what they did was look at suicide deaths over a 6-year period in over 1 million soldiers, and said, let's look at the period of the 1 year after people leave a psychiatric hospital. It turns out the risk of suicide death increases dramatically in the weeks after discharge from a psychiatric hospital and then comes down slowly over time. But this 1 year after people leave a hospital with a psychiatric diagnosis is a really high-risk period. What Kessler and colleagues did was said, let's look at every variable we can find on these soldiers in their medical record, in their electronic medical record, and in any other electronic data we can find on these guys. Let's use these variables, let's use machine learning, so we'll use these algorithms to learn what variables are most strongly related with suicide risk and what interactions are most strongly associated with suicide risk, and then we'll use those algorithms to predict in other soldiers whether they're going to die by suicide. So each hospitalization, there's over 50,000 different hospitalizations over this period, each hospitalization gets a predicted probability, which Dr. Youngstrom talked about earlier, a predicted probability that this person's going to die by suicide over the next year, using only data already available in that person's medical record. And we all, if you have healthcare, you have medical records, so it's a similar kind of thing. We look across your entire record and we say, what's your risk moving forward? Every hospitalization gets a predicted probability, and if we line them up from highest to lowest, from left to right, and these are just put in 5% bins, so that bar all the way on the left is the top 5% of risk scores. The first 2 bars, the top 10% of risk scores, all the way down to the bottom 5% of risk scores. What we see is, you see, and on the vertical axis is what proportion of suicides are in that bin. It turns out the top 5% of risk scores include 50% of all suicide deaths over the next year, which means if you think about predicting suicide as sort of people described as looking for a needle in a haystack, this is an approach that gets haystacks that have a really high concentration of needles. So again, just using available data, using machine learning methods, we can identify a really, really high-risk group. Whereas the risk of suicide death, the rate of suicide among soldiers in the Army is 18 per 100,000. In this group, it's 3,800 per 100,000. Very, very high risk. You may note, though, when you do the math, that means that about 4 soldiers out of every 100 that we say that this algorithm says are at risk, 4 die by suicide, 96 don't. So we have a lot of false positives, so that we still need to get much better. What's interesting, though, is if we then say, of people in this high-risk group, what percentage died by suicide? What percentage died by other means or had some other negative outcome? It turns out nearly half of them, if they didn't die by suicide, they died by accident, which may or may not have been an accident. They had a suicide attempt, or they had a rehospitalization for some psychiatric condition. So half the people in the high-risk group had some negative outcome, something we want to prevent in the next year. So I think fairly impressive results using big data to try and improve prediction. All done with data lying dormant in a person's medical or administrative records. And this has been replicated in a few other samples. Barack Cohen and colleagues did this in a very recent paper in the Harvard healthcare system. It's called the Partners Healthcare System, looking at 1.7 million patients, going through over a decade of medical records. This group was able to identify about 40% of suicide attempts, on average about 3 to 4 years before they happened. And they're in the process now of replicating this in 7 different civilian healthcare networks around the country. And the long-term goal here is, can we get better at using available data to tell clinicians, and what this is going to look like, I don't know. Maybe a little score pops up in your screen, your little dashboard saying, this person in front of you has a 0.8% of making a suicide attempt in the next week, a 0.7 in the next month, and then whatever in the next 6 months, and then you use that information to try and improve clinical care. These methods can also help us not just improve prediction, but identify new risk factors. So these are data from the Barack Cohen study. And what this is in that paper, they looked at thousands of different ICD codes, so basically codes in your medical record, and correlated them, or actually used them to predict subsequent suicide attempt. Those thousands were grouped into different categories, and how much each risk factor increased your risk of suicide is on the y-axis. This is called something like a Manhattan plot. If you look at genetic studies, the results of genetic studies, they call it a Manhattan plot because each dot here is some kind of genetic loci, and then the higher it is, the bigger the hit. And usually you'll see something that looks like the Manhattan skyline. This looks more like the Boston skyline, which has like 1 or 2 big buildings, but it's Manhattan plot. So we see all the different codes that could predict suicidal behavior here, and we see there's a huge hit, a big tower for mental disorders. So things like substance use disorders, personality disorders, alcohol use disorders, all increased risk. We know that. We know that from decades of research. What's really interesting, I think, is we see hits also for dermatological conditions, poisoning and injury conditions. These are things that weren't coded as being self-inflicted, and they're codes that have to do with having skin infections, arthritic infections, open wounds, burns, and so on. And what's probably happening is people are engaging in self-injurious behavior. We think, we don't know. They're cutting themselves, they're burning themselves, they're taking overdoses and saying, I accidentally took too much medication. They're popping up in the medical chart. Psychiatrists, psychologists, social workers never hear about them, but they're increasing a person's risk of suicide death. So the idea is we can use approaches like this to build models that help us get better at identifying who's at risk. So we can better inform clinician, hey, focus on this patient. You may not know it, but they have a high risk of suicidal behavior. Next point is we need better objective markers of suicide risk. Currently, what we're doing is relying on what people tell us. If we want to know if someone's at risk of suicide, we ask them, are you going to kill yourself? This is sort of the state of the art we have right now. It is. I mean, and you should. If you think someone's at risk for suicide, you should ask them. Half to 2/3 of people who die by suicide told someone before they died they were thinking about death or suicide or killing themselves. So you should take that seriously. On the flip side, people have an obvious motivation to deny or conceal thoughts of suicide because they don't want to be stopped. They don't want to be locked up in a hospital against their wishes. They don't want to be held in a hospital. We also know that suicidal thoughts are transient in nature. They're not persistent always. They tend to come and go. And so maybe a person is genuinely not suicidal now, but those thoughts could return later. We also know that many people, actually all people, all of us, lack conscious awareness of all the factors influencing our behavior. This may be especially true in kids who just lack the awareness or the assertiveness to report how they're thinking or feeling. So although we should take reports of suicidal thoughts seriously, we also know that denials of suicidal thoughts can sometimes not be taken so seriously or can be questionable. We know this because there's this high risk of suicide right after discharge, so presumably clinicians aren't letting people leave the hospital knowing they're at risk. Patients are convincing clinicians, maybe convincing themselves they're no longer at risk. We also know from a recent study, almost 80% of people who die by suicide in the hospital explicitly deny suicidal thoughts in their last assessment before dying. So the typical case will be someone says early on, I'm thinking about suicide or death. There's some kind of intervention, and then they recant and say, no, I'm no longer suicidal. And sometimes that's followed by suicide death. So what are we to do? How are we to know if a person's at risk? What we need is methods that assess risk of suicidal thoughts or behaviors that don't just rely on self-report, right? So what we have is what a person's telling us, a patient, a colleague, a friend, a family member. In this case, the person's saying, I don't want to kill myself. What we really want to know is, what is this person thinking about suicide? What are their unspoken thoughts or their implicit cognitions? Implicit cognitions being things that aren't reliant on conscious introspection and explicit self-reporting. Right? And we all want to know this. We want to know what others are thinking that they may not be telling us. Fortunately, social and cognitive psychologists over the past few decades have developed methods of measuring implicit cognition using people's behavior, using tests of memory or reaction time to get at the contents of a person's mind or mental associations. One method is called the Implicit Association Test, or the IAT. Who has heard of the Implicit Association Test? Great, just a handful of people. So I'll go through a really quick demo. Usually, and it's a test of reaction time that shows you different stimuli, asks you, they could be words or pictures, present it in the screen, and asks you to classify them to the left or the right. And it uses the speed with which you make these classifications to measure the associations you hold between different concepts and attributes, which sounds like a lot of jargon. Let me explain. It's used mostly by social psychologists to measure how people think about men versus women, Republicans versus Democrats. And I usually use a sort of political example as an example. Given the current climate, I won't. So let me just make up another one quickly. Let's say, best to not do that. Let's say I'm going to show you in the center of a screen, and I'm going to ask you to classify on the left or the right. I'm going to show you pictures of basketball players, 5 different basketball players randomly presented, and jockeys. And I'm going to show you also interspersed tall words, words related to being tall, and words related to being short. And you just have to, you have your finger on 2 keys. And what I want you to do is hit the left key as fast as you can if you see a basketball player or a tall word. Hit the right key if you see a jockey or a short word. And you do it as fast as you can without making any mistakes. We measure your response time in milliseconds. We'll have you do this, say, 60 times. Now we switch it. Now we say hit the left key for basketball players and short, and the right key for jockeys and tall. Go as fast as you can without making any mistakes. It turns out people are much faster responding when basketball and tall are paired than with basketball and short are paired. If you've got to pair basketball and short and jockey and tall to the same sides, it takes just a little bit long. And the reason is you don't associate those things as being like each other. You're faster responding, faster making classifications when you perceive things to be more closely associated with each other. It's a really nice little piece of psychological science. We wondered, can we use this to measure how people are thinking about suicide? So instead of basketball players, jockeys, tall and short, we set up a test very similarly that uses a stimuli of life and death, and is it like me or not like me? And so what we think is, if you're somebody who wants to die, who identifies with death or suicide, you'll be faster responding when death and me are paired together. If you're somebody who wants to live, you'll be faster responding when life and me are paired together. And so I'll show you a little example of what this test looks like. I know it's right before lunch. I would encourage you, if you're able, to just say out loud whether the stimulus in the middle goes on the left or the right. So death-related words, dead, dying, suicide, go on the left. Me-related words do as well, me, my, I. Life-related words, living, thriving, surviving, and not me words, they, them, theirs, all on the right. So death and me on the left, life and not me on the right. Ready, go. Okay, so we'll do it for 40 trials, and now we'll switch. Now we'll do the same task, and now we pair life and me together. I think you were a little faster on that one, which is good. That's what we want to see. And so what we do is we, in an early study, administered this test to a sample of people coming through a psychiatric emergency department, knowing these are folks at high risk for making a suicide attempt in the next few months. And so we administered this test, and what we find is people who are faster responding when life and me are paired, about 10% make a suicide attempt in the next 6 months. People who are faster responding when death and me are paired have 3 times the rate of suicide attempt over the next 6 months, and performance on this test improves the prediction of which patients make a suicide attempt above and beyond chart diagnosis, clinician prediction, Clinicians are no better than chance at predicting who's going to make a suicide attempt. So we asked clinicians in the ER, the clinician who was responsible for that patient, is this person going to make a suicide attempt? And we clinicians are no better than chance. We asked the patient, are you going to make a suicide attempt in the next few months? And we gave them Beck's scale for suicide ideation, so a continuous measure of severity of suicidal thoughts. Even after putting all those things into the model, this test improved the prediction. And Dr. Youngstrom wonderfully explained sensitivity and specificity, so we had a pretty good sensitivity and specificity with this test. We were capturing a lot of the people who made suicide attempts and accurately classifying people who didn't. Replication is very important in science, of course. We've given this test to many other groups. Shortly after we did this, there was a group in Canada who did a very similar study, and they found very similar results, almost the same odds ratio and sensitivity and specificity. So we have some indication that this test does work to help us identify people at risk for suicidal behavior. It's important to understand whether this effect exists more generally, so we've created a website called implicitmentalhealth.com where anyone with a computer connection can go and take these, a variety of actually death and suicide and non-suicidal self-injury IAT, as well as IATs related to anxiety, depression, and alcohol use and eating, and is mental illness associated with violence. It's a sort of educational website that you can learn about implicit cognition. You can take tests and sort of measure your own implicit cognition. We also use it as a research site. And you can go on anonymously and take these tasks, and then we will use your data, not linking it to any information about you. Do we see these effects replicate more generally in the general population? We administered this initially to 6,000 people. We randomly split them into two halves of 3,000 and 3,000, ran our analyses in one, tried to replicate them in the next, and the results replicated. Did we have a nice effect? We did. Notably here, the means are negative, which means most people, in all groups, responded more quickly when life and me are paired, but people who've attempted suicide, that association is weakened. The link between me and life is weakened. And on the right, we see the more recently someone's made a suicide attempt, the higher their score. So this seems like it does shift over time. And so we're doing an increasing amount of work to try and develop tests that can be used to identify suicidal thinking. One of only many different tests that could be used. What's nice is, in the past few years, we used to do these on desktops. Now they can be done on iPads, iPhone, or any kind of, I get no money from Apple, any kind of tablet or smartphone device, these can be administered. We're just finishing a study now where we're giving our best self-report questions and a few behavioral tests like this on tablets to 2,000 patients who came into an emergency department, following them up saying, if we run an algorithm over their medical record, we give them these behavioral tasks, we give them our best screeners, we get some blood from them, can we put this together and try and predict who's at greatest risk? So we can, again, if we can develop an accurate algorithm, give that information to clinicians once they give the test. So the model is in your outpatient practice, in your primary care office, in your emergency department, in your inpatient unit, can we collect data and use what we know from science to try and improve clinical decision making? So clinicians have the best information about whether a person's at risk of suicide, attempt, or death. The final thing I want to talk about is trying to get better at imminent risk. And for me, this is the most important area because, clinically speaking, this is what we clinicians are tasked with doing, knowing whether a person's going to hurt themselves in the short term. When we look back to Joe Franklin's meta-analysis, and this is years of going through the literature and finding thousands and thousands of studies and narrowing it down. Here, about 14% of studies were useful, so Joe was a little bit less grumpy than your student was. What we see is if we look at it and say, well, when we assess someone and then follow them out to see whether they engaged in suicidal behavior, how long out did researchers try and predict? It turns out that in the vast majority of studies, we're trying to predict 10 years out, 5 years out, 2 years out, 1 year out. Only about 20% of studies are we looking at less than a year. What percentage of studies look at the period of time that clinicians really care about? The next 0 to 29 days? What percentage of studies? 0.1% of all studies that researchers have done over the past 50 years have looked at the time window that we really care about. And so we don't have good information about short-term risk. So what we do is, and what I'm sure you'll hear about on Friday, is we do the best we can. We know what risk factors are. We know that simply adding up these risk factors can get us pretty good prediction of who's going to be suicidal over the next year, but we just don't have good information about short-term risk. And so we need studies that get at this. How can we do this? To editorialize, it's nuts and it's humbling as suicide researchers that we don't have data on this. If you think about any other area of science, biology, or I shouldn't say any, most areas of science, biology, chemistry, ethology, if you want to understand some problem, or even any phenomenon, flowers, stars, doesn't necessarily need to be a problem, you want to understand anything, you go out and you observe it. and you probe it, and you try and identify some kind of causal associations, and you get some understanding by firsthand observation. We don't do this with suicide. We don't observe suicidal thoughts or behaviors. The reason is we can't ethically bring people into our office and make them suicidal. We can do that with mood disorders, anxiety disorders. You bring someone in, you show them a tarantula or an alligator or whatever, and you can make them anxious and then study anxiety. We can't do that with suicide because we don't want to encourage people to become suicidal for fear that maybe they'll die by suicide. And we can't follow people around because it's weird and creepy to walk around behind someone and ask them consistently about suicidal thoughts and so on. So ethically, we've been in a little bit of a bind, and so we've relied on people's long-term retrospective self-report, and that's what all of our data are based on. But now, we can do what gets called digital phenotyping, a moment-by-moment quantification of individual-level phenotype or manifestation in situ, out in the wild, using a person's personal digital device. So if you think about it, I'm not going to ask you to pull them out, I bet everyone, if not almost everyone in here, has some kind of smart device in their pocket or on their wrist. We're essentially cyborgs, right? We're all carrying around this digital appendage that's constantly collecting data on us, on our most intimate thoughts and feelings and behaviors, how much we're moving, our GPS, where we're going, who we're interacting with. All of us are accumulating massive, massive amounts of data. We can start using these data to understand what suicidal episodes look like. How do thoughts and feelings and behaviors change leading up to and during a suicidal episode, or a depressive episode, or a manic episode, or before drinking, or whatever it is. There's a lot of data being collected that aren't being adequately tapped into. Doing this can decrease the influence of recall bias, as I'll discuss briefly. We can observe processes out in the world. What we do as sort of clinical psychological scientists is our best approach right now, and we do this all the time, is we bring people into the lab and try and approximate conditions that would lead to suicidal behavior or processes that would lead to suicidal behavior. Is this what's happening out in the world? We have no idea. But if we use data collected out in the wild, maybe we'd have a much better understanding. We can test theories about suicide out in the world. We can develop new theories, and I can tell you, I'm not going to show these data, but existing theories we're testing using data from out in the world, and things don't operate like we thought they operated. And perhaps most importantly, if we can identify who's at risk when in time and place, perhaps we can shoot them interventions. So as one example of this, these are data from a study by John Turos. This is from J.P. Onella's group at Harvard Medical School. What they did was measure depression in a small sample of patients. And what they did was give people a PHQ-9, a patient health questionnaire 9 symptoms of depression at baseline, and then 30 days later. So they asked about symptoms of depression at 2 points in time, and you see those graphed here. In between, on people's smartphone, they loaded the PHQ-9, or a program that administered those 9 questions, 3 questions 3 times a day. They used people's responses to those questions, so just a few seconds to complete, to estimate their PHQ-9 scores. That's the blue line. What you see is, using the smartphone app, symptoms of depression were on average about 3 points higher on the app than they were in the office. So people are feeling more depressed in real life every day than they're reporting to their clinician. People were also asked about suicidal thoughts, the PHQ-9s over the past 2 weeks. So the 2 weeks before this and the second 2 weeks during this period, no one reported suicidal thoughts. Those red dots are suicidal thoughts on the smartphone app. 69% of people reported suicidal thoughts on their app. So 0% reported it in the office, 69% reported at least one episode of above average, it's a 0, 1, 2, or 0, 1, 2, 3 scale, above the midpoint on have you thought about suicide? So some non-trivial suicidal thinking. The idea here is you can pick up lots of rich clinical information using smartphone data that you can't get by using self-report questionnaires at one point in time. And newer studies are trying to get richer data on suicide and related processes. So in one study, this is done by Evan Kleinman, who's in our research group. What Evan did was start following, using smartphones, people who are at risk for suicide attempts, people who are having thoughts of suicide. He had them load a smartphone app on their phone, and it beeps you 4 times a day and asks you a few quick questions about suicide and related processes. How intense right now is your desire to kill yourself? How about your intent to kill yourself? How much are you able to resist the urge to kill yourself? You just complete these 4 times a day. It could be 0 on all of them. It could be midpoint, it could be high, whatever it is. We're just collecting information to see when someone says they think about suicide, what does that actually look like? People are variable. So the blue and the green are the I have a desire and I have an intention. The red is I have an ability to resist. So for the first these are 3 different people. For the first person, and this is over a period of 1 month, so this person's having thoughts of suicide, having urges and intentions occasionally, and the resistance comes down when they have them, so the things work. This person has lower resistance, higher ideation, that's concerning. This person is a little bit lower and then peakier. What we did is look across 2 different samples of people, and we did what's called a latent profile analysis to say, are there certain profiles or patterns or potentially subtypes of suicidal thinking? Like, right? If we want to know about what are patterns in drinking alcohol, if we ask people, do you drink, have you had a drink? A lot of people say yes, but there's some people had a drink once, some people had to drink once a day, some people drink 9 times a day. So there's probably a lot of variability. So is that the case for suicidal thoughts? It turns out there is. There seems to be some variability here that is somewhat consistent. So each of these boxes, to orient you, is a different person. This is 1 month period, and this is severity of ideation. And so we generally see 5 different subtypes of people with ideation. The green boxes on top are people who have low mean, low variability. So they report very little suicide ideation. The people in the yellow boxes, these are sort of classified by computer program. The computer found these patterns essentially in the data, found these clusters of people. The yellow are low mean, some moderate variability. The purple boxes are moderate mean, moderate variability. The red boxes are high mean, low variability. They're thinking about suicide all the time. It's not really coming down. And the blue boxes are high mean, high variability. It turns out, this is a very small sample, but these effects we replicated in we tested, do these replicate in a second sample? We have the same 5 patterns, so it seems that this, to some extent, is robust. The people in the red were the ones who most recently made a suicide attempt. So it may be that that pattern is associated with future higher risk of suicidal behavior, although we don't yet know. What we're doing now is trying to follow people over longer periods of time to see, do people change their pattern? Do some people start out in the green box and then move to the red? And which of these types of patterns, if they replicate, are most predictive of suicidal behavior? But the idea is with richer and richer data, we can perhaps get better at understanding suicidal thoughts and predicting suicidal behavior. We can also do passive monitoring now. There are an increasing number of smartphone apps that don't just ask you questions, but they collect data in the background of your phone. So they collect data on your global positioning system. So where are you? How much are you moving around? Your accelerometer, in place, how much are you moving? On your call and text data. Not content, but how many texts are you sending to who? How long are they? Same thing for calls. Are they coming back again? Bluetooth, how close are you to other people who might also have their Bluetooth turned on and so on. And we can start to learn about people's lives using these kinds of data. For instance, these are data from my colleague J.P. Onella, and these are GPS data. This is one person on 2 different days. Blue is nighttime, red is during the day. And so this person was sleeping, and then they traveled to demystify. This is one of his research assistants. He may do this for, she went to work, she was at work, and then she went home, and then you see the light blue, she walked the dog, and was back home again. And this is a weekend, she didn't do too much. I mean, she might have done a lot, but she was staying right close to home. But the idea is, maybe from following patients who are potentially at risk, we can see this is indicative of mania, this is depression, or this is somebody who's healthy and active, and this is somebody who's not doing as well. If we see this over time, it could just be work day, weekend day, absent any other data. But if you enrich this with other data, these data could help us potentially with prediction of high risk periods. We're also, and others are doing study, incorporating biosensors. A lot of people wearing Fitbits and other devices that collect heart rate data, electrodermal activity, so it'll give us a rough measure of arousal, skin temperature, movement, and so on. And so we're doing work in hospitals now where we have psychiatric inpatients with suicidal thoughts doing these apps. We're monitoring them passively, and we're collecting real-time biosensor data and having them push a button on the device when they have thoughts of suicide. And we can see in different channels what kinds of patterns, biological behavioral patterns, might be predictive of suicidal thinking and suicidal behavior during hospitalization and then afterwards. No clinical implication now because it's exploratory, experimental, but down the road, a few years from now, might we be able to use these kind of data to then give information to clinicians, letting you know how your patients are doing in the hospital, shortly after discharge from the hospital. Certainly you wouldn't want to have constant data from all of your patients all the time. But for those who are at high risk during high risk periods, could we zoom in on those and get better at identifying when that's happening? The reason we want to do that is so we can better intervene. And I want to conclude by just pointing towards two types of intervention, or 2 examples of interventions that could be done. One is this really cool app that was created by a gentleman named Robert Morris at MIT. And it's called KOKO, K-O-K-O. And this is a crowdsourced peer-to-peer cognitive therapy app. he calls it a new solution to an old problem. The idea, and I have no stock in cocoa, I just think it's a really cool intervention. The idea here is cognitive therapy works for depression, but a lot of people don't have access to it, right? And a lot of people don't want to go in, or when they really might need it, perhaps is 3 o'clock in the morning on a Tuesday. And so what he did was create an app where people go onto this app and they say something like, they would say to their cognitive therapist, my boyfriend, girlfriend just left me, I'm a total loser, I'll never find someone again, I'll be alone my entire life. A cognitive therapist might help you identify your negative automatic thoughts and generate some rational responses and so on. What this app does is it has the crowd do that. So people who are trained to do this, and users get trained to generate reframes, reappraisals, and those get rated, and the good ones get bumped to the top, and the bad ones get screened out. But basically the person then sees peers responding and helping them to reframe. And Rob, there's a lot of apps out there, thousands of apps, most with absolutely no data for their effectiveness. What Dr. Morris did was test this in a randomized clinical trial, and he compared it to a writing condition, which has been shown to help people do better with depression and anxiety and so on. And what he found was people who got this Cocoa app, people who used it had significant reductions in depression, and the more they used reappraisal, the less depressed they were. He now has updated it with the idea that if you download, maybe some of you have downloaded an app. You download an app. My phone has like 30, 40 different apps on it, and I use 3 of them. And this is, I think, most of us. We use a few different apps. So a lot of people will download an app like this. They'll use it a few times. Isn't this cool? And they'll stop using it. What he's now doing is embedding this approach into people's messaging systems. So you might use your standard text message app, or you might use WhatsApp, or you might use Kik, or you might use some other text messaging platform. This is a little snapshot from my own cell phone. So I have Kik on there, K-I-K. It's a messaging app, and if I have Kik and you have Kik, we can send each other messages on Kik. Kik has bots running on it, this sort of AI technology. And if I type in, as I did, I'm depressed, the Kik bot just automatically says, well, you're feeling depressed. These guys at Cocoa may be able to help you. And then the Cocoa bot pops up and says, hey, sounds like you're having a hard time. Let me introduce you to this Cocoa technology. And they walk you through how to post and get feedback from it and so on. And so the idea is, maybe people, if we find them where they are, sort of like if you say to Siri or Alexa or whoever you talk to when you're alone, hey, I'm feeling depressed, I'm feeling suicidal, and try it. You won't get, with all due respect to all of the technologies, at this point in time, you won't get a great response because we don't yet know what the right thing to do is. How do we respond when people say, I'm feeling suicidal? This is one effort, is say, well, let's bring you into a community of people, have you talk about what's going on, and have that community respond to you. So a really nice, so far, approach that has been tested and shown to be effective. With some updates now, it'll be exciting and interesting to see penetration and effectiveness moving forward with this kind. This is one of many different approaches like this, but I think a nice example of how technology can be used to take this old traditional approach and bring it into the use of modern technology. Finally, we can use some mobile apps, and this is another piece of work by Joe Franklin, who was with us and now is a professor at Florida State. Joe created this approach called therapeutic evaluative conditioning. And evaluative conditioning is sort of like classical conditioning, where you pair 2 things and those things become associated. In evaluative conditioning, you do the same thing. You do the pairing, but you try and change the evaluation a person has to be positive or negative about that thing. And so what Joe and friends did was create this app that tried to create an aversion to suicide or self-injury by repeatedly pairing suicide with naturally aversive things. So it's a matching game. And so if you have kids or ever were a kid, you probably play this matching game where you see the faces and you turn upside down, you try and match them and so on. We have the My Little Pony version, and we have lots of ones that we use at home with our kids. Not in our lab. I have kids, and at home we do this. But in this app, in the control condition, we do a neutral pairing, so hanger, plants. And so you'll see this array of 8 tiles, and then all but the hanger will disappear, and then you've got to tap the hanger and the plants. You were trained to match those things, and you have to remember those things get matched. It's neutral pairings. In the treatment condition, you'll see the same array, and you might be trained to pair suicide-related images like pills with naturally aversive things like snakes or spiders. And so the same thing, you see this array, and then everything disappears but the pills, you've got to tap the snake. And so what you have to do, you do this a few minutes a day for a month, but the task is basically to learn to pair suicide-related images with naturally aversive images, snakes and spiders, and also to pair self-related stimuli with favorable stimuli, puppies and rainbows and so on, to help people feel better about themselves, because we know that self-critical style is associated with self-injury and suicide. So we're trying to make suicide more aversive and make the self more positive. And this was tested, it's this brief game like app, was tested in 3 different randomized clinical trials and consistently found to be effective at decreasing self-cutting, suicide planning, and suicidal behaviors over just a 1-month period. 3 trials, because we did the first trial, Joe did the first trial, saw the results, said this is really amazing, let's do it again, and 3 times we got pretty nice results. Brief caveat, got nice results in 1 month, and then followed people 1 month after that, and a lot of these effects went away. Meaning this seems to be an approach that could change people's behavior, but to have lasting change, we probably need larger doses. But the idea here is we can use new technologies to try and drive down some of these behaviors. So in conclusion, I think there's lots of opportunities for advance using electronic data, health records. I didn't even talk about social media data to get better at predicting, understanding and predicting and preventing these behaviors. We can now better detect and predict using objective tests. There's a lot that's been developed in the lab that we've got to port out into clinical settings. And we need to get better at short-term prediction and intervention, and I think mobile technologies will be especially good at helping us do this. A few things I didn't talk about, some key challenges. How do we deliver risk scores to clinicians and to patients? Not a trivial thing. If we're running an algorithm on someone's medical record, do we tell them, hey, you're at high risk of suicide in the next year? On one hand, yes, of course, you should tell a person they're at risk. On the other hand, if we've got 96 out of 100 of false positives, is this going to have some kind of harmful effect to the person? How do we tell the clinician in a way that they're going to use this information effectively? We don't know, and it's a really important question moving forward. Which assessments, which interventions work best for which patients? Are there heterogeneity of treatment effects? We know that from existing data, some people do better with cognitive therapy, some do better with interpersonal therapy. How can we match people to interventions in a way that gets their best outcome, optimizes their outcomes? And what are the ethics of monitoring people on social media, using their electronic data, on their smartphone, and intervening implicitly? Hey, here's a game you can play. When really the game is aimed at decreasing your anxiety or depression or suicide or self-injury. How much reporting should we do? On one hand, none. These guys at Amazon and they're not telling people, hey, you're looking at sneakers, guess what you're going to see next time? It's going to be an ad for sneakers. They just do it because they're trying to sell us things. So maybe that should be our approach. On the other hand, no. If we're doing things that could be harmful to a person's health, we have an obligation to let people know about this and make sure they're fully informed, especially if it's done in a research context. So a lot of exciting possibilities, but a lot of big questions to answer and address in terms of how we should best do this moving forward. Thank you so much for your time.
To reproduce the data that you had regarding,
I can repeat it.
Okay. Regarding the risk factors across cultures, you know, where you had the 5% and then you had the, you know what I'm talking about.
This is a true-false question? Yes. True. I don't know. Risk factors. The 5%, meaning the looking at people's medical records and predicting, or the meta-analysis saying, what do we know about risk factors for suicidal behavior?
I think it was the meta-analysis.
Okay, yeah, so we have a paper in press now looking at what do we know about racial, ethnic, cultural effects and these risk factors. The answer is, unfortunately, we don't know a lot because a lot of the time researchers aren't reporting about the variables that we need to know about these kinds of factors. If you're thinking about cross-nationally, in terms of cross-culturally, risk factors for suicidal behavior, yes. I didn't present this here, but we got dozens of studies looking across 24 different countries at risk factors for suicidal thoughts, plans, and attempts. And there's differences cross-nationally, cross-culturally in terms of base rates. But once you get past base rates, things look very similar in terms of age of onset is always, you see a huge increase in risk of suicidal thoughts during adolescence. A third of people who think about suicide ever make an attempt across all countries, cultures. A lot of the risk factors that we see in the US, we see across 24 different countries. So there's more consistency than there are differences in terms of risk factors for suicidal behavior. Does that address your question? Okay, great, thank you.